The most common example of phakic IOLs is the EVO ICL, or implantable Collamer lens. They're sometimes called implantable contact lenses, but Collamer refers to the highly biocompatible material they're made from. ICLs sit in the sulcus space anterior to the crystalline lens and posterior to the iris. They're available in 4 sizes based on their diagonal measurements: 12.1 millimeters, 12.6 millimeters, 13.2 millimeters, and 13.7 millimeters. 12.6 and 13.2 are the most common sizes. The EVO refers to the model with the central and peripheral ports to allow aqueous to flow freely in the eye. This also allows the ICL to always be resting on a layer of aqueous like a ball bearing. This makes them even safer than the previous models. It's important for ICLs to have the right space between them and the crystalline lens. If they're too small, they can rotate and risk being too close to the lens, and if they're too big, they can push the iris forward and narrow the angle. The space between the crystalline lens and the ICL is called the vault. An ideal vault is typically between 250 and 750 microns. For the FDA, they are approved for patients between 21 and 45, internal anterior chamber depths greater than 3.0 millimeters, spherical equivalent refractive error greater than -3, and fairly healthy eyes. That being said, many surgeons feel comfortable implanting ICLs in wider age ranges, spherical equivalents of around -250 depending on accommodative potential, and shallower ACDs. For example, in Europe, ICLs are approved in ACDs of 2.8 millimeters or greater. ICLs are available from -3 to -16 spherical equivalent with up to 4 diopters of cylinder correction. ICLs can also be used to debulk myopia to bring the refractive error in a range that can safely be treated by laser vision correction. Before surgery, like most refractive surgeries, it's important to know the current glasses prescription as well as how old it is. Also obtain a manifest refraction and cycloplegic refraction to assess accommodative potential. And many doctors like to obtain contact lens over refraction in higher degrees of myopia. The power of the lens is often chosen based on this contact lens over refraction, while the cylinder power is often chosen from the manifest refraction. As with any myope, it's important to perform thorough eye exams and DFEs to catch any retina pathology. For sizing, the manufacturer nomogram Stella uses a caliper white-to-white corneal measurement. Some doctors use other white-to-white measurements like the Pennicam, but many use more advanced imaging techniques. UBM, or ultrasound biomicroscopy, is often used to help size the ICL, as this imaging modality provides a very detailed look at the space where the ICL will ultimately sit. Nomograms that rely on UBM include the London Vision Clinic nomogram or ICL Guru. Exciting AI-powered solutions are on the horizon, like Vault, which can predict ICL sizes based on single anterior segment OCT images. ICL surgery is remarkably straightforward. A small paracentesis is created to inject epi-sugarcane and dispersive OVD. Then the ICL is inserted through a minimum 2.75 millimeter main wound. The ICL is tucked into place behind the iris, and the OVD is evacuated from the eye. This whole process takes between 5 to 10 minutes per eye. It's often done under oral anesthesia, such as Valium and MKO melt, so no IV is required. After surgery, it's not uncommon for patients to see better than 20/20 only an hour after the procedure. That was my experience when I had ICLs and my wife's experience when I was her surgeon. On post-op day 1, it's important to check IOP, as retained OVD can rarely increase pressure. It's also important to check vault. This is usually done with OCT, and anterior segment OCT can also take a quick look at the angles to make sure they don't look too narrow. Vision is typically excellent on post-op day 1, and patients usually wear goggles at night for the first week and take a combo Pred-Moxy drop 4 times a day for the first week. The follow-up schedule is typically routine, so 1 day, 1 week, and 1 month, then annual eye exams. ICLs are incredibly safe with a remarkably low complication rate. The most common reason that requires an additional intervention after surgery are rotated toric ICLs. This usually happens because the initial size wasn't large enough, so the ICL didn't sit snugly in the sulcus. These are often exchanged for a larger size. Sometimes there are sizing errors, over vault or under vault, which may require an exchange. At Parkhurst New Vision, for example, our exchange or explant rate for any reason is about 1%. Patients may report seeing glare or halos due to that central port, but these go away over time. This is what mine looked like, and after a couple months, I don't see them anymore. There are a lot of myths with ICLs. In residency, you might learn that they're fraught with complications and only for very high myopes. None of this is true. The EVO ICL is incredibly safe. The introduction of the central port has made them tolerant to an extremely wide range of volts. The cataract and glaucoma risk has essentially been eliminated by this port. Despite being an intraocular surgery, ICLs in many ways are the least invasive form of vision correction since they are an additive technology and they don't change anything about the anatomy of the eye. Lastly, while extremely rare, especially in the US, you might see lenses like the Artisan, which are also phakic IOLs, except they attach to the iris via claws, a process called enclavation. In summary, ICLs are a safe, effective, and unique solution for vision correction. They're completely reversible and provide some of the fastest recovery and best vision possible. They absolutely should be offered to anyone who could benefit from them, even for lower myopes like myself. EVO ICL is an absolute staple of any modern refractive surgeon.